A movement pattern will never hold, will never be taught if our nervous system perceives that movement pattern as being unsafe. Stop being so simple. Look further. Why wouldn't something fire?
Thank you for subscribing to the Frequency-Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Pittis.
Isn't that a fancy hat there, Kevin? I enjoy seeing my swag on other people more than I enjoy seeing it in my closet. But you're muted, so I can't hear what you're saying, but it looks pretty.
I was saying it's a pretty cool hat.
Thank you. That was worth unmuting yourself for. I'm just trying to get the height of this desk set up here. Carol's going to be a few minutes late, everybody. She's stuck in traffic. And it's funny because I thought I was going to be the late one because I was at the clinic until just a few minutes ago working with a fascinating person. And it dawned on me, like, I wanted him to stay and I couldn't get enough of treating him and trying to find out, like, he had just such an interesting story of somebody who's had chronic hip pain and is a triathlete and has done literally everything I suggested. Have you tried this? Yes. Have you done this exercise? Yes. What about this? Yes. This, that.
Nice.
It had stumped me for an hour. And then just as he was leaving, I had all these ideas. So he's an out-of-state person, so he gets to come back tomorrow. But I just thought about, as I was racing here, how grateful I am to have a job that I don't want to leave.
There's a lot in that, yeah.
Like, I don't know. I talk to so many people, whether it's like clients or friends, and they hate their job.
Yep.
And I get it. We all have to put food on the table and we all have to do certain things. But if you can be excited about your job and your day and what you're learning, and I guess that's why I think this was such a perfect profession for me, is because I never feel like I'm done trying to get better at figuring this stuff out. And I have since we have a couple minutes, I'm going to story tell really quick. I have to read something from this book, but maybe I'll wait for Carol. But we're talking to one of my daughters yesterday, and I've lost two. I only have one left at home who's in high school. So two have flown the nest and whatever. And my middle daughter is playing on a very good hockey team right now. And she's used to being one of the best, and now she's not. And that very new environment of when, and I'm sure we can all relate to it, when we're learning a new skill and we're excited about it, but we're not competent and we're not confident. And it's just this new environment for us. And I was telling her yesterday a piece of advice my dad gave me, and he said, if you're the smartest person in the room, you're in the wrong room. And I told her that. And I was like, if you were the best person on the team, you're on the wrong team. Like, you always want to be challenging yourself. And FSM injects that sort of mentality into everybody's profession. Like, even the most brilliant doctors and surgeons and PTs and chiropractors that I know that use FSM still get challenged and mystified and then consequently excited when we crack the code. It's like working with the Da Vinci Code every day. So I was telling her, I'm like, being in that environment where you don't feel like you're the best, that should also give you that spark to get better and to improve. And if we can get incrementally better at doing something every single day, I think we're living a really good life. I have so much to talk about. It's been such a crazy few days, but for the practitioners that are listening that get stumped, and I went on Facebook the other day to basically put on a poll, because I'm going to be doing some seminars in Canada next year, and I'm trying to plot out on the map, where do I want to go and where do people want me to come. And so when I got on Facebook, then I started reading all these questions and comments, and I understand the frustration sometimes when we're dealing with people that come in and they're not getting any better and we're stuck. But there is really still so much to look at when we get stuck with something, and talking it through is very helpful and sparking ideas. And sometimes it's calling in other practitioners to bounce ideas off of, or trying something new. So I just don't, as I'm talking about how exciting it is to not be the smartest in the room or the best on the team, my point is that when you're getting stuck and you feel like you are drowning in all of this frequency and A channel and B channel and wave slope and all the other things that you can play with, it is making you a better practitioner. And I really believe that. And I have been in it just a fraction of the amount of time that Carol's been in it. But when I hear her talking about, guess what I did? That's where I want to be when I grow up. I want to be doing this in another 20 years and being like, oh, I just figured this out, or this is actually working.
Yeah, I sit
And
outside of the room where she works in her room,
yeah,
and every
yeah.
day she comes out and she's, oh my God, I can't believe what I just did. Almost every day.
And if we can live with that kind of excitement and challenge, I think we should always be challenged. Oh, my alarm is going off. I have all these alarms leading up to 3 o'clock. I have the 2:30 alarm that's leave the clinic right now. And then all the other get your coffee and sit down and check your mic. But I think if we can lead a life where we're being challenged and surprised and grateful, I think we're doing good things. And I'm very grateful that we have Wednesdays. And it's so funny that we've been doing this for almost 5 years now. Could it have been that? Is it that long?
We're
Maybe
going to
not.
be I think this is episode 180. So that's a lot of episodes.
It's a lot of episodes. And I know we had started during COVID. So I always just think back, it started in 2020. Maybe it was 2021 that we had started. But it's just so yeah, it's just awe-inspiring that we still have so much to talk about. And my list doesn't seem to be going down. Like I feel like I have this list of all the things, all these talking points, and we never get through it because there's always some fantastic case that we have to discuss. So it's hard for planning and it's hard for transcription because there's never a theme. I want to talk about Bursa today, but we probably won't.
Yeah, when I read about what you're supposed to put on your YouTube channel to get the best results and all that, stick to one topic, make sure that every video has one topic, and you don't, yeah, we can't do that. But
No.
we make it simple and we get it out almost every week.
And there's always a dog that's interrupting us and things that are happening, everybody. But I what I like about our show is that it's organic. And that's what I really wanted, was it to be two practitioners that are talking about their day and troubleshooting it, and to have a bit of a forum for people to ask their questions, and to have this at zero cost for people to constantly get updated and inspired, because it's not just about proprietary information and turning a profit. I think Carol and I both feel very deeply about just sharing information. And if I think about my biggest, greatest mentors, they all gave information for free. Nothing was proprietary. It was all just, this is what I've done and you should try it. And I want to stay true to that. So I'm grateful that we have this platform to do it. So that being said, people who are listening right now, I'll put this out before Carol gets in and then we lose all track of sense and time. For Canada, we are thinking about the provinces that I was thinking was Calgary, because I used to live there, Winnipeg because I was born there, and Toronto because I have a lot of contacts there. So we have the West, the Middle, and the East. So if those are good, go ahead and send me an email and we can start getting locations. I already have a host for Winnipeg. And I see somebody has joined us in the background, had slunk right in. But yeah, I'm very excited to be heading up north back to my hometown, towns, and seeing all my Canadians up there because we can. So I barely got through anything that I wanted to talk about because I was talking about gratitude and all those things. And I basically just saying how I had left the clinic today just now, and I didn't want to leave because I was working with this athlete, and he had, I don't know if you get those people that every suggestion you give them, they have done. Every person, every modality, every stretch, every exercise, every training, anything I could say, have you tried? Yes, I have.
Oops.
And with that comes a little frustration, but also that feeling of, and I was explaining that saying, if you're the smartest person in the room, you're in the wrong room. And I've always wanted to learn and grow. And when I was racing here, I was thinking how grateful I am to be in a job that I don't want to leave. I don't want to leave at the end of the day. I want to keep staying and playing and thinking and troubleshooting. And if we can do that and be grateful for what we do, we are doing a good thing.
What could you do that is more fun than this? And then when the patient says, I've already done that and that, then that's when you start digging deep into your pile of what is it? How do I fix it? What is it really? As opposed to what everybody else thought it was.
Yes.
How do I go back? Bob Grimm, the neurologist that I work with, said, you start from scratch and ignore what everybody else said.
Yep.
Start from scratch. And then there was an orthopedic surgeon that where if he's been working with somebody and they come in the same condition 2 visits in a row, like literally, he talked to the patient, pause for a minute, he'd walk out the door, come back in and say, let's start over.
Yeah.
And who else does that except us?
I think it's so important when we have those super duper chronic complicated cases. And it's really hard because we want to get the history and we want to get a layout of what that person has been through and what's worked and what hasn't, and imaging, and we want to get that background. However, it can really give us a bit of a bias because we think we're looking at bursitis. And this was the case of this person. It was ischial tuberosity bursitis. And I don't discount the fact that his bursa and his ischium is irritated. He's a triathlete. He's sitting on a bike. But the bursa does not get inflamed from outer space.
Yeah.
So this was the big conversation of, you can shoot it up, you can do this, you can do that, but let's find out mechanically why that bursa is not going down or why it keeps getting irritated.
And it's trochanteric bursitis.
It's on the ischium, it's on his sit bones.
David Mesnick sent me a picture of
all the bursa.
18 bursas.
Yes.
It's like there is no one bursa on the ischial tuberosity. There's 12 of them.
But the ischium, his sit bones are his area of complaint.
And then there's the pudendal nerve, depending on what he's doing with his ischiums.
Yep.
And then you take the anatomy book out and you look at the ischiums and go, whoa, there's all that stuff there.
Yep.
Whoa.
Yes.
It's pretty fun.
It is so much fun. How I wanted switch lanes super quick. I was going to read a little excerpt from one of my favorite books while I was waiting for you, but then Kevin and I went down the gratitude tunnel for a little while. So everybody knows that this is one of my favorite books. This was Dr. Codman's very first edition of The Shoulder. And I wish you could spell it. Dr. Codman, as in
Codman's exercises.
Codman exercises. So this was the first edition, original edition, 1934.
Whoa.
Okay, so I snuggle with this book at night. It sounds creepy and weird. However, we know that a lot of our frequency histories were based on surgeons and osteopaths around this time frame. And if you read this book, it reads like a novel. He talks about things in the first part. It is a textbook. The shoulder, rupture of the supraspinatus tendon and other lesions in or about the subacromial bursa. Like that is a mouthful, Dr. Codman. But he talks about cases and operations, and he'll say things like, I diligently went in and moved in or about the tent. Like but what I want, as I reading this, and I do read this at night, like it's a novel.
Way to fall asleep.
No, it's so good.
It sticks in your head.
Something I wanted that I read and it jumped out at me because I think these sentences come out for a reason. And I didn't know this wasn't a bursa in the hip. This is talking about the bursa in the shoulder. He says, he's talking about formerly, before putting the arm in abduction, I used to give ether and open the bursa. The appearances of the floor of the bursae were always the same. A congestion over the supraspinatus tendon on the base of the bursa that looked like a bloodshot eye.
Yes.
So I'm thinking of different frequencies. So yes, we have a frequency for, what was the word that I just used? Congestion.
Congestion.
Congestion in the bursa and the tendon. I tried it today.
Yeah. Duh.
Amazing reduction in pain.
Yep.
And then when we see things like the bursa look like a bloodshot eye, we have frequencies for hemorrhaging and bleeding. And like this, the keys to the universe are in this book, I'm pretty sure. So I get inspired when, and then he's talking about, oh, hang on. The congestion area was usually circular with a whitish center, much as in the calcified cases, but no macroscopic calcified material was present. The adhesions were then found.
Adhesions were then found. Yes.
So he's talking about things where he thought were calcified, but they actually weren't. And then he was using adhesions. So again, I'm thinking of all our A channels that we're using with shoulders and bursa. And
any bursa that's been inflamed for more than about 8 weeks is going to get scarred to the periosteum and the overlying tendon.
yes.
Speaking of shoulders, I had so much fun yesterday. I have a family of 16-year-old, so they're triplets, and they play tennis.
Yes.
And
These tennis player stories.
yes, and this one of the girls came in and she'd been playing with her brother's racket. So her grip, his handle is bigger than hers. And she played 4 matches when they were gone for a week. And she said, and my shoulders sore. And she got to hear, not right. And I looked at her and I said, remember that thing where I put my fingers in your armpit? And she went, yeah. So we did, I went after the subscap and it still, after the subscap released, it wouldn't go into full abduction. And I went down along her rib cage and her lats. So the first time I saw them was 2 months ago, and fixed the shoulders. And I said, this is your lat. When you have to anchor your shoulder blade from the back, and you have to use your lat to serve, which means you have to plant your low back and use your back to do that forward internal rotation that you need for a serve. So in 2 months, her lat has gone from invisible to the bodybuilders. The thing is that wide and that thick. And I felt along the edge of it, and it was adhered right here where it always is at T5. So I treated the adhesions in the lat, and then her arms still wouldn't go into full abduction. And I went, that's not, wait, she's playing with a heavier racket with a bigger grip. I wonder. So I ran torn and broken in the labrum and took her humeral head and brought it here and just waited. And as soon as the labrum got over being, it actually wasn't torn, it just got beat up because she was serving too hard. And once the muscles relaxed, the humeral head dropped back. Then her shoulder relaxed. Then she had full and pain-free abduction. And we had to treat the bursa and torn and broken in the connective tissue, but it was torn and broken in the labrum that got the humeral head to seat. And I learned the hard way by pressing too hard on somebody and hurting them that you just wait until the muscles relax and the humeral head sits back into the labrum. And I'm not sure Codman ever mentions the labrum.
He does. I'll read more for story time another time. But
We'll do story time. But what you said about the bursa is absolutely correct.
And I want to go back to the labrum for a little bit. When we have athletes, when we have anybody for that matter, but especially when we have athletes, there is a certain amount of wear and tear that is going to happen on surfaces like the labrum and the meniscus.
It's not torn, it's just beat up.
It's like they're microscopic tearing. It's very similar to anybody that is building muscle. It's torn and then it repairs. And that's how we hypertrophy. We don't grow more muscle fibers. We're not frogs. The muscle fibers that we have just get thicker and bigger. So that's why our protocols for like workout recovery and DOMS work so well with the athletes, because they can tear things apart and repair them and get back to work the next day.
Yeah.
So
stop the bleeding.
And so if you would image athletes' rotator cuffs and hip labrums, and there are the labrum in the shoulder, the hip, and the meniscus in the knee, we're gonna see some degeneration. That doesn't mean there's dysfunction or pain, but and this is what I'm so excited about with the work that I do and the sports course / rehab course that I'm blowing up that I can't wait to share. When we want to give somebody corrective exercise, or whether that is a little bit of a muscle patterning exercise or a full out training program, there is one fundamental basement membrane that has to be in place. And that is a movement pattern will never hold, will never be taught if our nervous system perceives that movement pattern as being unsafe. And this is what we do exponentially well with FSM, is that we can create the safe to move foundation. And when something in the brain, and when something is safe to move, then the patterning will take place. But unless that is negotiated, you're never going to get pain reduction long term. These are the people that feel better after an hour, and then 2 days later, everything went back to normal, because that movement pattern, even though it's faulty, was perceived as safe, because if they didn't blow past a certain range, they wouldn't get pain. You always say what the amygdala gets paid to remember, and it does not negotiate or notify, right? These are all these things that I think of when I see movement happening. And so sometimes when movement has a bad pattern, it's not necessarily because something is adhered or it's scarred. We get people that write these movements off as, oh, their glutes are weak. No, it's not weak. Stop being so simple. Look further. Why wouldn't something fire?
Yeah. And I've got another one. Speaking of movement patterns and the brain, there's a patient that had 2 surgeries on her feet. Her right foot, after I treated it, was fine. The left foot, they had done a bunion surgery, then taken the screws out, and then some orthopedist decided that she needed pins in the second and third ray and to keep them straight. Surgeries cause bleeding, bleeding causes scarring. And I did a sensory exam on her feet, and the right foot they were both pain-free when she left. Right foot stayed pain-free. Left foot, she said the pain is like a 4 or 5. I said, when did it come back? At night when I went to bed. Okay. So pain that's worse at night is pain in the brain. It's centralized. That's a truism that you have to revisit. During the day when you're walking on it, you have ascending messages that compete with the pain messages that go up the spinal cord in the brain. So I did sensation in her toes again, and her two lateral toes, 1, 2, 3, 4, and 5, were numb. So went from her knee to her toes and did 40 and 396. And her pain went from a 5 to a 1 in 10 minutes.
Wow.
Okay. So you start mobilizing in between the rays, and then you mobilize the tarsals and scarring in the nerve, scarring in the periosteum, and then you get up to the tarsals. And if you think about it, her first and second ray, she's been walking in supination for 2-3 years. So the tarsals are all rotated outwards. So we did scarring in the joint capsules between the tarsals and scarring in the nerves, and started adjusting the tarsals while we're treating the nerves. I had 3 or 4 machines on this one foot, scarring in the nerve, inflammation in the nerve, but to get rid of numbness, it was increased secretions in the nerve. So that then things were coming good. And she got this funny look on her face. And I said, "What's that?" I said, "What's your pain level?" And the clue was, she said, "I don't know.
Yeah.
I don't know." That means my brain thinks I should be in pain, but I'm not. So I ran 40 and 89 from her knee to her toes.
Yeah.
And then I said, 5 minutes later, "What's your pain level?" And she said, "Oh, it's about a 2. Okay. So then we had to get this to move. We already did 40 and 89, but these two toes have been numb for 2 years. So we had to connect them to the sensory motor cortex. So we went from 40 and 89 to so quiet the pain part of the brain, to increase secretions in the sensory motor cortex, 5 minutes, and then increase secretions in the cerebellum, and then move your toes. And she said, "I can't move those toes." And I said, "Just try." And she did that. I said, "Now lift them up." Oh, then she did that. And then pretty soon, scarring in the nerves, scarring in the periosteum, remove why they're not moving, then tell the brain not to be afraid of it. And then the sensory cortex hasn't heard from them in 2 years, so reconnect that. And then you have a movement pattern because you've got the whole chain.
Yeah.
And it was so fun.
And that's like why we spend 3/4 of a day doing this in the sports course, because it's just brain candy. And I think that concept it's not unique in the way that it's this outlandish idea, but it's the ability to help connect those dots for somebody that otherwise I'm not sure
But ever. And
is that weird to say? I don't know. I don't want to say ever, but
not in our world. Yes, if you're lucky, and if the patient is not too traumatized by 2, 5, 10 years of pain, if you're lucky, the brain will do it eventually on its own.
sure.
Or not. But the fact that we can manipulate it in real time. And then she stood up and she said, "There's no pain."
Right.
Okay. Before you leave, I went and got a dry towel, put it on the floor. And I said, "I want you to do scrunchy exercises with your toes." And she said, "I can't do that with my left foot." And I said, "Oh, just try it."
Right.
And her left toe, I said, "They're weak, but just try it." So in first tentative, then stronger and stronger. So by the 10th rep, both feet are equal.
Yeah.
And so you take it from manipulating the nervous system to having the patient use the peripheral system,
Yeah.
and we're back to the rehab course.
Right.
Then you do the patterning with the patient doing it actively
Yeah.
without cueing.
Correct.
But it's because we can connect the whole chain. There's nobody else that can do that.
I don't think there is. I and I love that we have a community because I need to geek out with people about this. And I love treating other practitioners. I'm treating one of our local chiropractors in town who does not do FSM, but she just geeks out whenever we do anything. This is amazing. And she's an athlete too. She's a runner. So she understands the progression of things. And this is it's just so interesting to see somebody get as excited about it as I do. And the phrasing, I want to touch on this a little bit, what you had said. We have people who are in pain for a while or have that, have the belief, no, it's not even a thought, it's a belief that they cannot do something. And we never want to say, of course you can, or just do it. I'm not that trainer who's screaming and shouting. And this last training cycle, my last race that I did, I trained a little bit different than I have in the previous years. I took a very long taper. I did a lot of different types of runs, and I did a lot more yoga and meditation. It's very different. And the yoga instructor that is in the studio above my clinic has very interesting phrasing that I was using. So instead of being very judgmental with our left and our right, it was like, approach your left and right with curiosity, or what would it look like if you did that? And that phrase really stuck with me. So when someone says, I can't scrunch up my toes, I'm like, why don't you show me what it would look like if you could? And that kind of
Good
changes it.
idea.
What would it look like, or what would it move if you could do this? And then you're approaching the movement with a little bit more open-mindedness of, I don't know what it could look like. And then they're doing something. And they're like, oh, it is actually externally rotating. It is flexing. Because it is hard to rewrite that belief system, even though we know, especially when we're able to passively move something, we know the range of motion is there, but having them actively do it is a completely different story.
To take that same principle, which is brilliant, to take that same principle when you have a chronically ill patient, mold, MCAS, long COVID, right, for 5, 6, 7, 8, 10 years. As part of the history, one of the questions should be, what do you want to be able to do?
Yeah.
What would it be? What would you do if you could do whatever you wanted to do?
My verbal question is, what would it look like? What would your life be like if this wasn't a limiting factor anymore?
Exactly. Yeah.
And when you attach, and I don't know the psychology behind it, but when you attach that forward thinking, positive outcome, it changes a lot of the physical presentation of what they're doing, especially when it's things like, I just can't wait to pick up my grandson off the floor.
Mm,
I just want to be able to hold somebody.
yeah.
Or so,
Have somebody touch me and
right,
have it not hurt.
right,
I want to be able to work part-time. I want to volunteer at my church.
right,
I want to have more than 2 hours a day of functional time.
right.
Okay, our goal. So they establish in their own mind what their treatment goal is,
Yeah,
and then you work around that
totally.
or towards that.
Yeah. And you always say you can't want it more than the patient. And that unfortunately doesn't happen for me because I do want
Oh,
outcomes. And if you care about people as much as I think most of us do, that is probably the hardest factor for us as practitioners, is to want that positive outcome, to go faster than what it is, or to want it at all, because some people do source us out to get rid of pain or improve their quality of life. However, and you had seen this, I believe, in the fibromyalgia study, some people quit because they are getting better. And that is a whole other concept that is very hard for me. But
Do you have one of the nice things about working with athletes or even former athletes who are now chronically ill, they still have the I want to do it mindset.
yeah,
And in an athlete or even former athlete, they have that mindset. There are patients, the way of saying it is if a patient's pain or illness or disability is the only power they have in their life, the only voice they have, the only out they have, it's unreasonable to ask them to let it go. They'll get as better as they can. And then the only reason I say you can't want it more than the patient wants it, though, is because it broke my heart
yeah,
to want to know that I could get them to recovery and to want it for them. And I'll hold the vision for 6 weeks. And then you watch what they do with it, how they behave, and check in with them along the way. You don't want to push them. What are we doing today? And then it's just too painful
yeah,
for the practitioner. And I don't want practitioners to get blindsided by that unusual phenomenon, because what happens for FSM practitioners is we get more and more difficult patients until we get to that patient. And then there must be a way of that I don't know how. There must be a way, maybe your yoga teacher knows how, to get that patient to want it, to get that patient to see their power, to
right.
see, to not be afraid of having that vision, because they're almost afraid to hope.
And that is, I think that's a very important concept, especially people who have tried so many different modalities that have had hope sprinkled and then had it snuffed out. And that is, I think, part of the importance of having a custom care, that they have some power over their rehabilitation and their recovery. There is something that they can do that will make them feel better should something go sideways. And something will go sideways. That is what rehab is like. That is what retraining is like. You are going to re-injure something along the way. As long as we move, we are going to have these side steps. They're not back steps. They're just lateral movements.
There's also, that's life.
Yeah.
So I'm fine until I walk very carefully down the steps, because when you fall down the steps, bad things happen. And then, so life is a sequence
Yes.
of recoveries.
Yes.
That's the title of the next book. Once I get that 2 weeks off to write it, is Resonance Recoveries. And it's not just about physical recoveries, which we're really good at. So there's stories about that. But there's emotional recoveries. There's how do you hope? How do you, all,
Yeah.
all the kinds of recovery that we do on a daily, weekly, monthly, yearly, lifely basis.
Yeah. Yeah.
It's, and it's, to me, that's the other exciting part about going to work, is you get to participate and facilitate that recovery process on so many levels.
Absolutely.
Just because just the fact that our practitioners hold the vision that, oh, that's just a disc bulge and nerve pain. I can fix that.
Yeah.
The fact that we have that ability for something that's so difficult for everybody else, just that makes us unique as a group.
One of my favorite referrals was within two professional athletes who, and we talked about this a little bit this morning. I don't put it on social media. I don't jock sniff. I don't disclose it because A, it's unethical.
You're
And
not allowed.
first and foremost, and two, first and foremost, it's not about making money and putting things up. If the athlete wants to post it, that's one thing. But a lot of them deeply value having that secret weapon. And yes, it's frustrating. It'd be really nice if everybody would just be like, I do this, but there's so many athletes across so many different sports that do these little tiny things that they hold sacred to themselves and believe that's their secret weapon.
If
And
FSM is their secret weapon, the only reason I could tell the Terrell Owens story
it's
was
because
that Terrell already had it in his book.
exactly.
And
Yes.
that's
Yes.
everybody else that I've treated and that you've treated that people would recognize with 12 different professional teams or Olympic sports.
Yeah.
You've got way more stories in that arena than I do. You can't, there's HIPAA,
Yeah.
and then there's professional ethics,
Yeah.
and then
And
there's the personal relationship because them trusting you.
yes, and that is what I hold more deeply than anything else. And that one story I was just going to say, the referral between two pros, he's like, you have to talk to Kim. And the side comment was, dude, she's really going to listen to you.
Yep.
And I was like, wow, the fact that was not that I got somebody better faster, but the fact that I really listened to somebody, because a lot of athletes as they go through the path from semi-pro or to the minors to the majors become pieces of meat to the
I was
organization.
going to use that exact phrase. They're used to being treated like pieces of meat.
Yeah.
It's
And I
not
know a lot of us
personal.
think these athletes have it made because of the money that they're making. Some of them don't make the money that they think they do. Some of them have zero management of that money. But the day in and the day out pressure and the fact that you're just a number and you are utterly and completely replaceable is devastating to me. Like, these are human beings that deserve to be treated and to be listened to. So that is my favorite part of my job.
Yep. And back in the day when I was treating professional athletes, I took pride in the fact that I didn't know their averages. I didn't know what college they went to. I didn't know their sprint speed. I called them by their first name. I
Yes.
refused to call them by their trade name.
Nickname or yeah, exactly.
And it's your, I'm Dr. Mom or Dr. Carol, and it's a personal relationship with somebody who actually cares how you feel and cares that you get better for your own sake, not because you're making $6 million. It's that I don't care.
Yeah.
I want you to do what you want to do.
Yeah.
It's magic. We now have
We have
questions.
so many questions. I know. And because we started late, let's get through them. Helen, it was an osteopath. It was orthopedic surgeon. His name is Dr. Codman.
Codman's exercises for
Codman's
frozen
exercises.
shoulder.
Yeah. Those are all those pendulum ones that most of us know. So he's got a couple books, but that was the shoulder one. And I love it.
Question
Okay.
would confirm client operated on 5 weeks ago for severe headaches. Excised a large cyst in the sinuses behind the nose, putting pressure on the brain. Whoa, dude. Found no cancer, considerable infection, creating a lot of pus. Post-surgery, numb tongue. Couldn't swallow at all. Oops. Has improved. Sensitive. Yeah. Vagus. If they can't swallow, it's vagus. Sensory to the tongue is, I'd have to ask Mary Ellen, but the vagus is part motor to the tongue, I think. Medulla, cerebellum, lateral ventral, cerebellum, cranial nerves, vagus for sure. And not swallowing at all is pure vagus. And the key is that there are fibers of the vagus in the sinuses. And when they went in through the sinus, the other thing is there was an infection in the sinus creating a lot of pus. I don't know that they tested them for mold. In the advanced, the 4-day advanced, we were actually in the hot tub at Edgefield for our annual staff retreat,
Oh,
planning the afternoons of the 4-day advanced. And I found from Ben Catholi, I found a list of Georgia's experimental cranial nerves and have had success with some of them,
good.
not with all of them. And so that's going to be in the advanced part. Yeah. So treat for infection, test for mold, because the infection didn't come from space.
Yeah.
Treat for staph. Strep in the sinuses is most common, not staph, except for Marcons. And there's that. Substance abuse recovery seems like those who try to keep their habits all fall back into using due to physical withdrawal symptoms. We have a DVD from Bill Billica, who runs a rehab center in Fort Collins. He's Roger Billica's brother. And it's called Inner Balance, and it's an addiction recovery center. The physical withdrawal symptoms, especially for opiates and meth, are just awful. There's just no way around it. Every substance that is addictive has withdrawal symptoms because of the receptors that they fry and attach to. And what happens when, especially with opiates, like you fill that receptor and the brain says, wait a minute, we had an opiate receptor. There isn't one there now, so I guess I should make another one. And then you fill that one. And that's why opiates, you need more and more to get the same effect. And as you withdraw, you still have this expansion of receptors that have an opinion about no longer having a key in a lock. So we have two frequencies, let's say for opiates and morphine. So try those in the parts of the brain, like the midbrain, the medulla, the cortex, the vagus maybe, but the midbrain, the sensory motor cortex, because they just get a lot of body pain. And then reduce inflammation, I guess. But go to Bill Bellica's workshop, but you're going to have to watch the Roger Bellica's neurotransmitter workshop first. And then
Which is
the
amazing.
addiction. Yeah, it's like,
You don't have to watch it. You get to watch it.
yeah, yeah. Is it okay to talk about the issue, the treatment, and the result without giving the names of professional athletes? Maybe not as we talk about the injuries, and so that's the treatment and the result, and we do that all the time.
Yeah. The only thing I would add, if you are treating a pro, and depending on, I'll just use hockey for an example. If you have a high profile player who is injured, the media will not always disclose what the actual injury is. They'll say Carol McMakin is out due to a lower body injury. So if it ever leaked out that Kim Pittis was treating Carol's fibula for a hairline fracture, like I would just always be very careful of the details and maybe wait for some time to pass when all those little nuggets were out. That's just me being extremely private and careful over what I do. Or you could change. I get it. We want to share and talk about results. I would just change things
Yes.
a little bit.
And practitioners that have never treated patients or people that are in the press have no idea. I don't think I didn't until I treated Terrell.
Yeah.
And then the people after him, but the amount of press pressure that is out there and how any little nugget they'll fight for, like dogs on scraps.
Right.
It's, yeah, so you have to be really careful about how you disguise the identity of the patient. So because of HIPAA, we're always in a position of having to disguise the identity of patient by changing something.
Yeah.
When you're treating a professional athlete, you multiply that by 10.
Exactly.
Yeah.
Yeah. And the athletes that I talk about in the sports course, there's some pictures, they have absolutely given their blessing to discuss the cases because either they are retired or they're more than happy to share that information. They have signed this. So yeah, it's just, you said when you're dealing with a professional athlete that has, a lot of money riding on contracts and their health, so there's a lot of details that they don't want to disclose because then they're maybe seen as a liability, or do you know what I mean? So sometimes the only information that we ever hear is lower body injury, and there's a reason for that.
And then after you treat them and they recover, the only thing anybody ever knows is they're back to work in 6 weeks. That's
Right.
what
So a
they,
lot of times we don't hear of what we do until after that person has retired, or
and I
that's
don't want to
okay.
hear it in the press. It's no, thank you.
Yeah. Yeah. Unless cases like Terrell, who was giving that information and thanking you afterwards. And yes.
Yeah. But it was after his book was published, which was maybe a year later. And then it was like, oh, I'm in 2 sentences on that page. So there we go.
Those are
I
good
want to
stuff.
talk about one other thing. Do we have time? Where are we?
Of course. Yeah, we're good.
Okay, 5 minutes. Yesterday, you're welcome, Annie. Yesterday, I treated somebody for Monday and Tuesday. He had nerve pain in both legs. I had no imaging. He didn't bring his imaging reports with him. He had nerve pain in his arms. His no complaint of neck pain, but the first day he was in so much pain, I just treated his facets in his low back and did a sort of exam with him laying supine on the table. And I did the Babinski, and his big toe went up on both feet. Okay. He's 77. And so the next day I did the complete exam, and he still has a positive Babinski. And he can't stay in one position long enough to treat. And he's so nice and such a wonderful human. And at the end of the second session, when he could only, I mean, we put him in the rocking chair and reclined him and then sat him up and then reclined him and changed his position for him. And he could still only tolerate 30 minutes. And I went, look, I knew his GP who referred him. And I said, this is ketoprofen and lidocaine for your low back. You need an MRI of your neck. And I can't help you if you can only be treated with 6 machines, including 81 and 10 and 40 and 10 and facets and nerve pain and discs and nerve pain for 30 minutes. I can't, FSM is not your solution.
Right.
He said, you mean you don't want me to come back on Thursday and Friday? And it's like, you can come back and we have tea downstairs, but I'm there's has to be a different solution. It's like, this is a maintenance problem, and I've written the notes, ketoprofen and lidocaine, MRI of your neck, keep an eye on that low back, try some medication. He has no nerve pain, hyperesthetic nerves. I said, this is a maintenance problem. And you and your MD, he said, I've already sent her the notes and we'll take care of that. And I said, I'm really going to miss you. And he said, I've never met a therapist or a doctor that would do that. that would be straight with me. It's going to take me 60 minutes at least or more with you in one position, or at least with contacts on you, to be able to do this. And we got it. Yeah. So that's the other thing I like about us. It's put the patient first, and we do that.
And that maybe goes against, we could treat anything and there's a frequency for everything. But I think what you just said is we put the patient first, and I feel like we're real with people. And because we have so many professions with different scopes of practice, I do love the fact that I can feel like this is not my wheelhouse, or there's something else going on. I'm going to send you to this person, and we all can collaborate and share and give ideas. Or sometimes it is just being straight and saying, I'm probably not your best fit. And there's nothing wrong with that, like at all.
And bilateral pars defect, like the back of the vertebra is not connected to the front at L4.
Yeah.
L4 is 9 millimeters forward. L5 is 4 millimeters back. And okay, then.
Yeah.
And nobody's going to want to do surgery on that. And so putting the patient first, and that's what we do when somebody easy comes in with a little labrum and sore muscle and nerve adhesions and nerve pain and vagal dysfunction and easy stuff. Yeah.
That's my alarm.
It's 4 o'clock.
4 o'clock.
Keep me stuck in traffic.
Yeah, but that's going to happen. And we just make those adjustments. We just pivot. That's what we do.
Yep. Flexibility. And we're going to be in Rome. We have already 30 people signed up for Rome.
Of course you do.
We've got another room for another 10. And then Costa Rica is in November. So if you know anybody in South America or anybody that wants to come to Costa Rica, I vote for that.
Yeah.
But Costa Rica is our entree to South America. We have maybe 3 practitioners, 2 in Ecuador, 1 in Brazil, but he took it ages ago. So move that along. Speaking of which, just a quick public service announcement. One of the practitioners who took the course in 2004 said, I'm thinking of taking the core again. Chris, it's completely different. That's a really good idea.
Yes.
So.
Yes. Yeah, it's changed. And yeah, it's
large part because of you.
Yeah.
Because the whole thing that we've developed and that you codified in the sports, I was doing anyway, but I hadn't put it into slides and made it part of the core until 40 and 89, 40 and 92, 81 and 92, 81 and 84. It's just, so there you go.
We're all contributing however we can.
My team today called it the hive mind.
Yeah.
That's what the advanced is. It's the group coming together.
Agreed.
So we'll see you all.
What a group we are. So we'll talk more about this next week. But
that's right. There's next week.
We always have next week.
Yes.
All right, everybody. Thank you once again. And we'll see you all next week.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.